chest that examiner wants you to know. What's of your chest? All right, so we move on. We said the anatomy of the chest, okay, boils down to what we find in the cavity, all right, the thoracic cavity. And now this thoracic cavity, okay, we have, okay, fast fingers as usual, okay, thoracentesis, all right, thoracentesis, okay, paracentesis or thoracis, okay, aspiration of any fluid from the pleural cavity called paracentesis thoracis, paracentesis, okay, thoracis or thoracentesis, okay. So it's usually done in the 8th intercostal space. All right, so that's number one. Okay, so we are still talking about the plural. Yesterday we started, and now we said plural is what? Number one, it is a serous membrane. Okay, the plural. Okay, okay, we said the plural. Okay, is a serous membrane. Okay, or invaginating sac made up of visceral layer and parietal layer. A connecting part, okay, is called the root. It's a connecting part or the root. Okay. Now, the visceral pleura is also known as the pulmonary pleura. The visceral pleura is also known as the visceral pleura is also known as the what? The pulmonary pleura. Okay, because it encloses tightly the lungs. It encloses the lung tightly. It encloses all the surface of the lung, even extending into its fissures. It is deficient at the hilum of the lung. What's the hilum of the lung? Yesterday we looked at the hilum of the lung is the what? It is the root of the lungs. The hilum of the lungs is the root of your lung. All right. So the visceral pleura is continuous with the parietal pleura at the hilum of each lung. Okay, and then it continues there and then adhere together to form pulmonary ligaments. Now let's look at the parietal. Parietal pleura is the outer layer that lines the thoracic cage or wall. The parietal pleura is made up of 4 parts. We've seen it MDCC: costal, diaphragmatic, mediastinal, and cervical. Say the cervical pleura, okay, is also called cupula. Cupula. The parietal pleura is okay. So thank you very much. So we are still making progress. We said the plural, all right, the parietal, we've talked about the plural to be what? A serous invaginating sac, or it is a lining, a membrane that lines the lung. The pleura is a membrane that lines the lung. The pleura, okay, is what? Is an invaginating sac, all right? Meaning invaginating means it forms a kind of hulu, okay? A kind of hulu, something that was straight now invaginate and bulge, kind of bulge, okay? So and what makes it bulge is because of the serous fluid. The first thing we've talked about is the meaning of pleura. All right, the next thing we are talking about is okay, is the another name we call the part of the pleura. And then the next thing we talk about is the what? Is the parietal. Okay, so the parts of the pleura we have visceral and parietal, and the visceral is also called pulmonary pleura, whereas the parietal pleura here, watch this now, has four parts, and there's a part that is called cupula, all right, cupula, and this cupula is what? Watch this closely. The cupula is also the cervical pleura. Okay, now you see the parietal pleura is held onto the thoracic cage by loose areolar tissue known as the endothoracic fascia. So as we talk, okay, parietal pleura, we said it is held. These are short MCQ question you should expect in your exams. Short MCQ question. These are short MCQ question. Now, don't forget where we are coming from. Don't forget where we are coming from. Yesterday, in the video we had, we talked about IPC SHOR. Okay, IPC shop. What is IPC? Introduction of plural, parts of plural, that's for P, and then C is for what? C is for clinical relevance or significance of plural. S is for surface anatomy of plural, and then H is for the hilum of the lungs, and then R is for the role of plural or the recesses or reflection of plural. Okay, so now moving away from there, we talk about today, we are now adding another thing. We're looking at plural again in another light, in another material, because we said, what is it in your chest that the examiner wants you to know? So we didn't say examiner, we say examiners. So if you are only looking at one examiner, is a challenge. You need to look at more examiners. By looking at more examiners materials, so we look at a certain examiner's material yesterday. Today we are looking at another examiner material, Dr. Ugu. All right, so let's move on. This material was written by Ugo. He was a doctor. Okay, so we look at plural. Say the visceral is also called pulmonary plural, and then we look at the cervical plural. It's also called what? The cupula. Cupula is CUPOLA. And then we have the parietal plural. That one is held by thoracic fascia. Is held by what? Thoracic fascia. What kind of thoracic fascia? Endothoracic fascia. Endothoracic fascia. Okay. Now, the exothoracic fascia is called what? The exothoracic fascia is a superficial fascia, the deep fascia, find it between the skin and the muscle. All right, we've done a video on that. Go and check it. That one was so charming. Oh, it was so charming. You need to go check out that video. All right, so we're moving away from there. What else do we pick? These are revision, especially if you watch the video we did in live session yesterday. I think that video should be ready before evening. Okay, it's under YouTube Vault for algorithm to filter and check if it has any issue. All right. Now we talk about the costal pleura. They said this part of the pleura that lines the thoracic wall, it overlies the internal surface of the sternum, the transversus thoracic muscle, okay, the ribs and its costal cartilages, okay, the innermost intercostalis muscle and the bodies of the vertebra. So this is just additional information. So when you mention costal pleura, okay, it has about 5 things, okay, that is the sternum internally, all right, the ribs, okay, let's put it the sternum internally, the transversus thoracic muscle. Remember, the transversus thoracic muscle is divided into 3. That is, we call it sister, SIS. S for what? The subcostalis. I for what? Intercostalis. And the other S for what? Stenocostalis. Okay. So now we have internal surface of the pleura. Okay. Now, the it overlies the transversus thoracis. It also overlies the what? The ribs. Okay, the ribs and the costal surface. The ribs and costal surface. Transversus thoracic muscle. Okay, and the sternum. And then the last thing it overlies. Okay, the next thing is the intercostalis, intercostalis, okay, innermost, innermost what? Intercostalis, innermost intercostalis. Then the next one we also find is the body of the vertebra. So if you look at this, it becomes STRIB, stripe, C stripe. Okay, C stripe. So as the costal plural is made up of stripe. Okay, we've started again. Oh, costal plural. What are the things it overlies? Because we say the plural lines the thoracic wall. Okay, S for the inner sternum, S for sternum, T for the transversus. Okay, transversus thoracic muscle. You won't really appreciate this muscle except you look at the thoracic wall. There's a video we make, okay, on thorax, right? So you will not really appreciate plural if you don't appreciate the thorax, one before two. The thing that cover it, when you uncover it, when you understand it, you now see this other one. Okay, let's talk about diaphragmatic and mid-external plural. The diaphragmatic plural is the part that lines the thoracic surface of the diaphragm. And then the costal plural is continuous with the mediastinal plural anteriorly behind the sternum or sternal reflection and posterior in front of the vertebral column. Do you follow? And the mediastinal plural is the part that lines the lateral boundary of the mediastinum. You can see it in the structure. Okay. Now cervical plural. This is very important. It is a continuation of costal plural. So that is to say, you have diaphragmatic plural. From there, you have mediastinal plural, where you can have costal and lateral. Okay, let's move on. It ascends from the medial one-third of the clavicle up to the apex of the lungs to reach the lateral part. To reach the lateral part, I hope the message box is open. Okay, I think the message box is open now. Okay. Okay, so we've talked about the things that make up the costal plural, STRIP, stripe. Okay, S is for, it means the costal plural lines the sternum. Okay, the inner part of the sternum. Okay, all right, and then it is there is the transversus muscle, it lines that. Okay, and then what else? The out is the rib, the costal part of the ribs, the innermost intercostal muscle, and the body of the vertebra. Now the visceral plural, we've seen some information about it. Okay, continuous with the parietal plural at the hilum of each lung. Okay, let's look at the connection or root. The connection or root. So this is present at the medial aspect of the lungs where the mediastinal plural continues with the visceral plural. It is upper half and is transversed by the root of the lungs as the hilum of the lungs, while the lower half is empty but for the presence of lymphatic vessels. This part is known as the pleural as the pulmonary ligaments. Okay. Progress. Line of the pleura. Reflection. External and costal reflection. Remember yesterday we talked about the costo CMCD, costodiaphragmatic reflection, recess or reflection, and then costo-mediastinal reflection. Okay, let's move on. The knowledge of the limits of the sternal and costal reflection is high in clinical importance because it marks the limits of the pleural cavity, which will easily be endangered in surgery involving the upper abdominal compartment. Okay. Now, just a quick one. Tracing the extent of the pleura is very important. We trace it yesterday night. And why we trace is that if you want to extract fluid from the pleura, because the pleura, okay, is made up of the viscera and the parietal. In between it, the serous fluid can reduce or increase. It can be pneumothorax. It can be pleural effusion. And if there is pleural effusion, to remove that fluid anteriorly, you need to be able to trace, okay, where the lungs ends and where the pleural starts, so that you'll be able to tell where to place the needle. Do you follow? Be able to tell where to place the needle. And when you are able to place the needle well, guess what? You can extract it. So now we said on the front, because the pleural does not look at the lungs. It does not have a straight, look at the lungs, does not have a straight square, all right, diagram. In front, it stops at 6. So if you want to place needle has to be at the 7 intercostal space. Now we call that mid clavicular. If you want to remove the fluid from the side, which is the mid axillary side like this, okay, mid axillary, you have to place it at the 9th intercostal space. The pleural ends at the 8th intercostal space on the mid axillary. Now, if you're removing the fluid with the night, you look at it from the 11th, okay, intercostal space. That's posterior because the pleural ends in the 10th, the lungs ends in the 10th thoracic spine. Okay, now let's move on. So let's look at this. To trace the extent of the pleural in the living body, the following even numbers of ribs act as a guide: 2, 4, 8, 10, and 12. Meaning, the cervical pleural descends anteriorly, passing behind the sternoclavicular joint as the commencement of the right and left sternal reflection. Okay, left sternal reflection. You can see. All right. Then, excuse me, let me take some water. Wow. All right, let's continue. So that is these 8, 10, and 12 are very, very important. Plural. Each descend behind the mandible to meet at the mandibulosternal joint, which correspond to the point of articulation of the rib 2. Both sternal reflection will continue downward close to each other to the level of the forecostal rib. Here, the left sternal reflection will deviate laterally, while the right will continue downward up to the back of the xiphoid process. Is what they mean. See, there's a deviation by the left. Then by the right one continues to continue to descend up to the 6th costal cartilage. It then stands deviating obliquely, crossing the 8th rib at the mid clavicular. You see it now. The 10th rib at the mid axillary, and the 12th rib at its back. Now we continue. You can see the right one, where the pleural lies. Okay. at the right. We have the right syphis costal angle, the right costovertebral angle, the left costovertebral angle. Okay. These are the areas where the pleura are in danger of laceration in case of what? Okay. Now, pleural cavity, potential space lying between the viscera, okay, and the parietal pleura. Now, let's call this pleural space. Okay. Pleural fluid. We say 5 to 10 ml. This is a recall reminder to what we've already internalized. Pleural cavity contains this amount of fluid. Okay, so we move on. Talking about the pleura, we said the pleural fluid, you see the quantity in ml. Now, since the hydrostatic pressure greater in the capillaries of the parent of the parietal pleura, then in the capillaries of the visceral pleura, okay, pleural recesses. The pleural cavity, though encloses the lung, the lung does not fill all the spaces within. Do you see that part? Lungs does not fill it. So it allows some structures that are called openings, whether fluid opening or solid opening. All right. Just a second and we'll be back, please. Or just a minute, please. Okay, I think we can continue. Now remember this video, okay, is all about what's on the inside of your chest that the examiners wants you to know. And we said the first thing that's inside of your chest, the examiner wants you to know is the lungs. And the lungs has a pleural. So when you do dissection, you have the skin, the fascia, deep fascia, superficial fascia, thoracic cage, thoracic cavity where you have the lungs. And before the lungs, there's a pleural. Okay, you can see there, you can see the pleural there. Okay, where is it? You can see the pleural here. Okay, this is the pleural. All right. And the pleural we say is an invaginating sac that is made up of what? Both the parietal and visceral parts. Okay, so we said, in short, we say it's a membrane that lines the lungs. It's a membrane that lines the lung. Okay, and we've also talked about that this pleural, okay, the visceral part is also called the pulmonary pleural. All right, while this parietal has 4 parts, okay, we say MDCC. All right, and then not only that, we also said this plural, all right, the C there, which is cervical, is also called what? Cupola. Cupola. Don't forget, yesterday we talked about the cardiac tamponade. Cardiac tamponade. It's one of the clinical challenges that can happen around the pleural. Okay, now we've talked almost up to where we start the left. All right, so we move on. We've looked at the left and right sternal reflection. Okay, so the left reflection descends downward at about 20-25 millimeter. Okay, to the lateral edge of the sternum. Okay, and then It continues to descend up to 6 costal cartilage. That's the left reflection of the pleura. Okay, left reflection of the pleura. And the right reflection, okay, from the back of the xiphoid process, okay, the right sternal reflection crosses the 7 costal cartilage, okay, crosses the 8th rib at the mid clavicular, and thereby, so what do they mean by this reflection? Where you can pick the pleura, okay? So the pleura is exposed to where? Pleura is exposed where it lies beyond the thoracic cage, okay? So the right sternal reflection is at the right cervicostal joint. So we talk about the right the right sternal reflection. The right sternal reflection. Come on, God help me. I need to find an easier way to explain this thing. The right sternal reflection, we have CXC, that is coastal vertebral angle, right coastal vertebral angle, cervicostal angle. This is cervicostal angle. Okay. Now, pleural cavity again. I think we've talked about all this. Okay. Pleural cavity. You have the serous membrane. Okay. Now, he said it creates an intrathoracic pressure because it's a ceiling. The pleural fluid, okay, of 5 to 10, we already said that. Pleural recesses. Pleural cavity though encloses the lung, but the lung does not fill all the spaces within pleural cavity. The space within the pleural cavity is devoid of lung, is known as the pleural recesses. Okay, so so he said the pleural cavity though encloses the lung. The size of the pleural recesses is determined by the respiratory activity of the lung. It increases during inspiration process and decreases during expiration process. Pleural recesses. Now, the 3 areas where the lung does not fully extend include the left costomediastinal recess, the right costodiaphragmatic recess, and the left costodiaphragmatic recess. Okay, so these are the 2 places where the lung does not fully extend into. Okay, so meaning the CD we talked about has left and right, because the lung does not fully extend into those places. Okay, so that's why there can be reflection, there can be reflection, there can be recess. Okay, this additional information now. The left costomediastinal recess lies anterior to the foot and the feet. Left costo, okay, is foot and feet. Now, okay, at this point, the left lung is deficient where, okay, don't worry, we are still trying to pull out points. These are materials someone say we should see what we can do. And this is the first attempt. Okay. Here the heart and its pericardium are covered by a double layer of parietal pleura. Okay. This marks the area of the superficial cardiac dullness. Wow. Right and left costal diaphragmatic recess lies along the corresponding side of the costal arches. The point diaphragmatic pleura comes in contact. All right, let's look at nerve supply. Nerve supply. The two parts of the pleura receives a different neurovascular supply. Okay, let's look at it. Intercostal nerve T1 to T11, phrenic nerve C3, C4, and C5, nerves of pulmonary plexus, vagus, and sympathetic. Okay, let's now pick the distance. Now we've seen the structure. So he said the two parts of the pleura receives a different neurovascular supply. The parietal sensitive to pressure, pain, and temperature. So it produces a well-localized pain and is innervated by the phrenic and intercostal nerve. The blood supply is derived from the intercostal artery, internal thoracic artery, and musculophrenic artery. If you remember thorax very well, okay, we have the supreme intercostal artery, we have the internal thoracic artery, we have the costal cervical artery, we have the deep cervical artery. Okay. Now, but in plural, it's a musculophrenic artery supplies it. And the vein drains mostly into the azygos and internal thoracic vein. So we're talking about plural now, once again. The vein okay, so the vein drains into azygos, and internal thoracic. All right. Then the artery that supplied, we said internal thoracic, or let's put it this way, intercostal and internal thoracic artery. So internal thoracic vein drains it, internal thoracic artery supplies it. Azygos vein also drain, intercostal artery also do what? Supply. But the name that for parietal we said phrenic and intercostal. And we said this one sensitive to what? Pain, pressure, and what? Temperature. Okay, so that's one thing we pick from this session. In neurovascular supply, we have visceral plural. Okay, for visceral, what do we have for visceral? Visceral only detects stretch, not touch. or temperature. Okay, say viscera only detect what? Stretch, not pain, not touch, not temperature. Receive autonomic innervation from pulmonary plexus. We have pulmonary plexus. Okay, supplies it. Okay, pulmonary plexus is from vagus nerve and sympathetic trunk nerve. Now, arterial supply, the bronchial artery, branches. Okay, let's move on. Bronchial artery, that is branches of aorta. Branches of aorta. All right. Moving away from there, we talk about the lymphatic drainage. The lymphatic drainage. The lymphatic drainage for the parietal, and there's the one for the viscera. So parietal drains to the what? Intercostal and mammary internal mammary, posterior mediastinal and diaphragmatic nodes. While the viscera, okay, drains its limbs to where is drained by bronchopulmonary lymph nodes. Okay. All right. So that's a good one. The bronchopulmonary lymph nodes, okay, is the only thing that drains the visceral bed. For the parietal, we have number one, so we can put it D for diaphragmatic lymph nodes, posterior mediastinum, internal mammary, so dim. Okay, P dim. Now moving away from there, we are still tracing the lymph. You can see in the structure, the pleural fluid filtration, costal lymph, diaphragmatic lymph, and mediastinal lymph. This is for parietal pleural. There are four. P dim, P mid P, deep M, deep. So we said deep M is very deep, where D is the diaphragmatic node. Okay. I is intercostal node. P is posterior mediastinal node. And M mammary internal mammary node. Deep in, or you can say deep. So I'm deep, I'm a deeper. So that's another way we build it here. I'm deep. Okay. So moving away from there, talk about the development of plural as embryology. Each long bud invaginates the wall of coelomic cavity and then grows to fill a greater part of the cavity. The lung is covered with visceral pleura and the thoracic wall is lined with parietal pleura. The original coelomic cavity is reduced to slit-like space called the pleural cavity. Okay, it's a result of growth of the lungs. Okay, that's why you say the pleural cavity is the region enclosed by the lungs and the pleura. All right, by the lungs and the pleura. Okay, anatomy. So the plan anatomy, the relation of the pleura to the 12 rib is of importance. Okay, during renal surgery. This is because the medial border of the kidney lies above it. Let's see if we can get that. So number one, we said twelve rib, in renal surgery. Okay. Medial border of the kidney lies above it. That crosses the 12 rib at the lateral border of the muscle rectus spinae. In situation where it does not extend beyond the lateral border of rectus spinae, 11 rib might be mistaken for the 12 rib. When incision is carried along the 11 rib, it will lead to laceration of the pleural cavity unknowingly. To avoid this, the rib should be counted from the sternal angle, where the second rib is most prominent. So this sternal angle Siena angle. Wow, that's great. So it's something we call rectus spinae. So we are going to, this is not really a familiar material. We are still looking at it. So what do we find? The 12 rib and renal surgery because of medial kidney at where? Above the pleural. The rectus spinae. What do we say about that? We said the rectus spinae, applied anatomy number one, is the medial border of the kidney lies above the pleural. Now the pleural crosses the 12 rib at the lateral border of the muscle rectus spinae. But the situation where it does not extend beyond the lateral border of the rectus spinae, the 11th rib might be mistaken from the 12th rib. And when incision is carried along the 11th rib, it will lead to, as you see what we were talking about yesterday, if we are not careful now, we have issue. So you study more than one material. Yesterday we ended up saying, this is very important. Yesterday we ended up saying you insert, okay, in case of pleural effusion, pleural effusion or pneumothorax. Okay, what happens is that you have this structure here. I have this structure that is what? It's called rectus spinae. Now, if rectus spinae, if the pleural does not extend beyond rectus spinae, so the pleural crosses 12 rib, okay, the lateral border of the muscle, this. Now, in situation it does not extend beyond the lateral border of the rectus spinae, the 11th rib might be mistaken. So what do? You count your rib from second rib because it's most component, most prominent. Okay. And we've already said something about pneumothorax. Okay. Sucking pneumothorax, tension pneumothorax, close, open, and tension. Cut. Cut. Closed, open, tension. Closed, open, wow. So as we talk about pneumothorax, look at pneumothorax in 3 different ways. When sucking pneumothorax, also called open pneumothorax. So we have cut, open, or sucking. It enters in open pneumothorax, and then the condition leads to hyper expansion of the normal side, and the condition known as the mediastinal flutter, where the content of the mediastinum will shift to the normal side during inspiration and abnormal or injured side during expiration. Wow. So here there is what? Mediastinal flutter. Okay, it's mediastinal. And then moving away from there, we have tension, we have close. What happened in close? Here, this ATM is less than what? The atmospheric pressure. Okay. Now, this one, what's tension? Here, air moved into the pleural cavity during inspiration, but could not leave during expiration. This contention arises when the penetrating wound on the thoracic wall and on the lung acts like a valve, allowing in one-way flow of air. This condition, there is hyper-expansion of the thoracic cavity with the mediastinal shifting towards the normal side. So in tension, there is hyper-expansion. There's hyper-expansion and there's what? There's hyper-expansion, okay? And there's what? There's a valve, kind of as a valve-like wound. You see? So that's what they're trying to show. The chest pain, shortness of breath, asymmetric chest expansion, upon percussion, the fetus may be hyperresonant due to excess air within the chest. Pneumothorax can be included artificially after surgery of the lungs. All right. Hemothorax, hydrothorax, pyothorax, pylothorax, pleurisy. These are still situations of the lungs. If they only look at 5, today there are new ones. Okay, we have pylothorax, pyrothorax. Okay, this is what each of the pi is. Pylothorax. Okay, a pleural cavity is known as hemothorax. This could be as a result of injury. A condition where there is fluid in the pleural cavity is known as hydrothorax. When it becomes infected, to result in pyotemach. infected pleura. When there is accumulation of lymph, is pylothorax. You can put it now. Pylothorax is pause in plural. Pylothorax is lymph. And the pylothorax is pause. Epiema. Okay, so we move on. We are still extracting information. Pyrothorax. We already know. Pneumothorax. Pneumothorax has three: the close, the open, or the sucking, and then there is what? Sucking, and then there is what? There is, okay, I think. So we are still working on thorax. We are still, working on plural. And we said, okay, let me put, okay, we are still working on plural. We talk about pylothorax is when there is lymph. Pylothorax is for pulse. All right. Hydrothorax is for water. And the hemothorax is for blood. Okay. Pleural effusion is when there is increase in pleural fluid. Okay. Okay, from 5 to 10 mil is okay. But once it increase to 300 mil, it's a concern. That's pleural effusion. And the last one we're looking at is parencentesis. Parencentesis thoracis or thoracentesis. So we have paracentesis or what? Thoracentesis. What is that? Aspiration of any fluid. Okay. Aspiration of any fluid from the pleural cavity is called paracentesis or thoracentesis, usually done in the 8th intercostal space in the mid-axillary line. A needle is passed through the lower part of the space to avoid injury to the principal neurovascular bundle. Yeah. Okay. So that's that. Parasynthesis is the cure for pleural effusion. Pleural effusion 300 ml in adults rather than 5 to 10 ml. Okay, so with this now we've come to the end of this session, and then from 9 o'clock to 11 o'clock, 9, 10, 11, we've been slow on this, trying to push this point out bit by bit. And what point have we picked out? Okay, we've picked out number 1, the applied anatomy. Okay, pick out the applied anatomy, where we have pylothorax, we have pyothorax, we have pneumothorax, we have hemothorax, we have hydrothorax, we have pleuritis, or what do you call pleurisy, pleuritis or pleurisy. Okay, pleurisy, pleural effusion. Okay, then we have a solution for pleural effusion, which is parasynthesis or thoracynthesis. Parasynthesis or thoracynthesis, the aspiration of aspiration of aspiration of the aspiration of from the pleural. Aspiration of from, we look at that. Next, we look at the lymphatic drainage for the pleural, parietal, and for the viscera. Okay, now for the parietal, we said we have what? The deep, the M deep, that is deep, arm deep. IM is internal mammary lymph node. D is diaphragmatic lymph node. I is intercostal lymph node, and P is posterior mediastinal lymph node. While for the viscera, it's just one structure. The viscera is just structure, and that structure is nothing else other than the lymph called bronchopulmonary lymph. Bronchopulmonary lymph. That's what drains. Okay, the visceral pleural, bronchopulmonary lymph node. Then we talk about neurovascular bundle. We said internal intercostal artery. Okay, intercostal artery. Also talk about internal thoracic artery. Itai, itia, itai. Okay. Now, that's just a summary of what we have done so far. Then we also talk about the venous drainage. This is blood supply. The venous supply, we said, this drains into what? Internal intercostal vein. Okay, just like it's supplied by intercostal artery, It drains into intercostal vein. Okay, that's for the parietal. This is parietal. Okay, for parietal, you have intercostal vein. We also have what? Let me take water. Okay, so tired. Okay, but we are going on. Tired, still target. Because you notice if you take a break now, the whole tiredness is gone. It needs laziness. And you can't recall those things you learned. That is not true. So after every study, you recap. What can I remember from what I have done? If you don't achieve that, never beat your chest that you've studied. You should be able to say, okay, the pneumothorax, pylothorax, pyothorax is pause formation in the invaginated sac. All right. Then don't forget, we talk about the part. Okay, excuse me. Okay, and the coastal. We mentioned cervical plural in yesterday's video. Today, the coastal, we said, coastal plural make use of stripe. That's sternal, and thoracic, rib, and post. So those things now follow. See, the intercostal muscle, the rib, the transversus thoracic, all right, and then the body strip, body of vertebra, okay, strife, vertebral body, you can say strife, strive to make it, okay. Vertebral body. Then we talk about the other types of the reflection, left and right reflections. Okay. So most importantly, the blood supply for the plural. Talk about blood supply for parietal. Blood supply for parietal, what do you have? What do you have? Talk about the blood supply of the parietal. We have what? Okay. The internal intercostal artery, the internal thoracic artery. So we said AI, ITA, AI, ITA. That's artery intercostal, internal thoracic artery. Then which other artery supplies it? Those are two arteries that supply musculophrenic. Musculophrenic artery. And before the blood supply for viscera is just the bronchial artery. Bronchial arteries. Moving away from there, we talk about the vein. What are the vein? Intercostal vein. For the venous drainage, okay, internal thoracic vein and the azygous vein. Remember when we talk about the drainage of the other, remember when we talk about the drainage of what? The drainage of the thorax. He said from ascending lumbar to the subcostal, inferior vena cava drop a branch that also sent to the subcostal. Subcostal sent to the hemiazygos. Hemiazygos sent to the accessory hemiazygos. Accessory hemiazygos drain into the azygos. Azygos drain into the superior vena cava, which drain into the right atrium. Okay, so now we are making progress. So we're able to capture the blood supply, the vein supply, and the venous drainage. All these structures, okay, supply them. Then the nerve, we said, it is the phrenic nerve and is a phrenic nerve, okay, and which other nerve? Intercostal nerve. Whereas this one is supplied by the sympathetic, they call it a pulmonary plexus, which is from vagus nerve and sympathetic trunk nerve. Pulmonary plexus, which is vagus and sympathetic. All right. So we write a test now. Write a test now. I'm going to run through everything now. But let's pick the nerve. The nerve that supply this guy is the okay, we talk about the nerve, the vein that drains this guy okay, so we're going to check the veins that drains the viscera. If there's no venous drainage, that would be a challenge. For there to be brachial artery supplying it, to be brachial vein returning it. Okay. So for the lymph, we have P and deep for the visceral bronchopulmonary. So that's about the heart. For close, facial feature of close is A from womb, from A from lung wounds, okay, or lung parenchyma. All right. Then another thing we talked about, I said A enters on expiration. Next one is pleural Then you talk about the open. That one is for what? A from wound of trachea. Open is from wound from where? Thoracic cavity. For cavity. Every respiration increases hyper expansion. Mediastinal fluter. Moving on. Then finally, okay, I'm trying to list some basic one because you see, thank you for still being online. Thank you for still being patient to go through this video. You see, to bring out thoughts, first you have to extract it. Then you have to examine it. Okay, try to say it, to express it. A stammer is not really easy. Once these thoughts are coined, now share it. So for me to be consistent, instead of doing it alone and I doze off, okay, I do it online. Someone might come, may encourage, might find the video boring, might find it's not like other video. But this video was saying what is in that your chest that the examiner wants you to know. Okay, now you see how strange it is, unexciting material, but by the time we come up with an inspiring short video like this, wow, I love this. This is see, it's not really always nice. It's not always nice, but you have to give it what it takes. Okay, so in the afternoon we are meeting by 3 p.m. And these things that I've taken pains to pull out one by one, I'm going to make it more exciting in the afternoon, God sparing our life. So don't miss the afternoon session. The link is already there. Okay, you can see the link is already there. I'm going to be more refreshed. I'm going to go rest. I'm going to rise up, still check on this thing again, come back to it because this is the last day of the month and we're going to achieve something in thorax, abdomen, pelvis, and perineum, upper and lower limb. All right. And then by tomorrow, like I said, we start head and neck, we add physiology. Yeah, same tomorrow. Anatomy of it. It's going to be chain walking chain, straight. All right. Straight, we walk chain. Not going to be easy. I have a whole lot to do. I'll be working like that every now and then from time to time, every now and then from time to time, every now and then. Okay, to make sure we get the best. Because to get something, you must give something. And the time may come, I may be working into the night. All right, live session, lot of work into the night. So if you can join me, because month of August, I have a friend who gave me a target. He said I should help him so that he can complete some question and answer, all right, before he gets back to the month of September. So that means I have a whole lot of work to do. And if you can join me, fine. All right, I'll be sending the link and I'll try my best. Join the channel because I can access this on now. Okay, I'm leaving that. I'm going to focus on the channel now. So those in channel are really those that I'm going to be working with in August. All right, because many people are not serious. Maybe because they don't have exams yet, or maybe because they're in holiday, or maybe because nobody has really told them about this yet. Okay, no problem. So I'm going to give them some gap because we're used to something and all that. So that's that for that. I don't want to take much time. With this, we've come to the end of this session. I promise you, afternoon is going to be wow. We're going to combine this with what we have done before in the other material. And we're going to have a super work on thorax, a super work, on pleural. Okay, so we can know this thing that's inside the heart. Is that okay now? Thank you very much for being part of it. So what is inside the heart? It is pleural. Most heart pains, okay, most heart shortness of breath, we can see that it's not really a small thing. It can be caused by wounds in the parenchyma of the lungs or the trachea. Okay, that is uh, close pneumothorax. Can be caused when there is a wound on the thoracic cavity straight and the air enters. All right, for every respiration can lead to hyper expansion. There's a tension, there's a one that's as a result of tension, where once the wound occur, all right, it acts as a valve, cannot go out. Okay, so we're going to be looking at these things slowly and one by one in a most summarized way. See, now this material is so wide. How many? 40. No problem. We are going to reduce this material 40 to just one piece of paper. Promise you. Come in the afternoon, 3 p.m. This thing that I see as is making my video long and dull and whatever. No, I don't think so. I look at it as if dull means dedication, devotion. Up there is until I like it, until I light it, until I love it. Do you get? You are diligently on it until lighten up. So that's how personally I look at study, and you'll be fine, I promise. So ladies and gentlemen, if you have not subscribe, give a thumbs up, like and share. Let other medical students get to know about this channel. Much more video like this. Let them know what is in their heart. That examiners are what? Are after. Very important. After. Okay. Thoracentesis is when you are placing needle on the pleural to drain. You can see it. Pleural thoracentesis. This is on the posterior surface. Pleural space filled with excess serous fluid. See, fluid pushes on the left. There's no fluid on the right. Okay, so that thing has to be removed. Okay, all right. So once again, thank you for being a part of this session. It was a wonderful time. For the first time, we clear a material. Okay, that's why you don't talk about piecemeal here. Okay, because we've not internalized, we've used that to extra. Don't worry, in the afternoon, you are going to enjoy the piecemeal. All right? Thank you and goodbye. See you at the top of success.